El siguiente ponente es Paul Grossfeld, que va a hablar sobre la puesta al día del tratamiento médico de autismo y discapacidad intelectual en Jacobson.
Maybe extra time, would that be okay?
Yeah, okay. ¿Eh? Sí.
All right, I promise no bad Spanish this time, only English. Thank you again. So what I want to talk about in the next half hour or so is the work that we've been doing. First, to characterize the intellectual and behavioral problems, some of them, and then identifying some of the genes, and most recently, some what I would refer to as gene-based therapies. Well, I think already just when you look at the children that are here for this conference, and this is consistent with what we have observed for many, many years, what's very impressive is how much variability there is in the intellectual abilities. So the first part of my talk, I'm going to again describe, some of this you've heard before, but we have some, I think, preliminary but exciting new data on gene-based medical therapies, specifically for the children that have the largest deletions that are the most severely affected, as well as children with autism. And then in the end, I'll talk a little bit about more empirical medical therapies, in other words, that aren't based on any specific gene at this point in time. So just to step back, as a parent myself, I think I appreciate also that kind of helps me to drive what our goals should be. Like any parent, any pediatrician, what we want to do is help your children to maximize their potential. Specifically, we want to develop medical therapies based on our understanding of the genetic causes, combined with potentially other less specific approaches that will help your child potentially to have the ability to live independently as an adult, but also without compromising any of their beautiful personality traits that they already have. So our very focused approach is to perform, first of all, high-resolution mapping, like you heard from Teresa's talk, so we can begin to correlate the problems with the deletion size, and that way we can identify candidate genes. So we have the team of people that I told you about, specifically Natasha and Sarah and others, to perform these very comprehensive standardized testing assessments. And then from the mapping data, we can identify potentially candidate genes that we think may be the cause of these problems. But as you know, there's obviously only so much one can do with humans, and so we can turn to animal systems, which actually are remarkably powerful to study some of the same problems perhaps that your children have. And with that information, thanks to some collaborations that I have established, we now have potentially some specific medical therapies that target the function of these genes that are involved to restore that function. I've shown this slide many times. This is, again, Edgar, or the first child I ever saw with Jacobson syndrome. This is his missing chromosome, a test that you won't see very often these days. I think you can appreciate what's missing. And again, we've used this array CGH or microarray technology to define exactly the breakpoints to identify the genes. And these are some of the standardized age-appropriate tests that have been used by my colleagues to determine their intellectual disability and behavioral issues. And these are standardized tests that are done in many languages, I'm sure Spanish, so should not be a problem moving forward to do the same kind of assessments on your children if Spanish presumably is their only language. Oops. So some initial results that bear out sort of our preliminary observations. There is a very wide range of IQ, from low normal to quite severely impaired. And actually, contrary to what was alluded to, there is a very strong correlation between the deletion size and degree of impairment, which I'll elaborate on in a few minutes. And in chromosome 11, the region where your child is affected, we have identified at least 4 locations that we think probably have a gene or genes involved that contribute to the cognitive problems. And the one that I'll talk a lot about is the one that contains this gene called BSX1. And that gene is the gene that we think is responsible for the most severe intellectual disability in the children that have the largest deletion. And I'm not going to go over too much detail here, but this is just our way of sort of describing, showing where these genes are. So the TEL is the end of the chromosome, that's the telomere, and as you move up, meaning with a bigger deletion, you see more severe intellectual disability. And then for those with interstitial deletions, there can be, it depends which regions are affected. Basically, any interstitial deletion that includes region 1 is probably going to cause pretty significant intellectual disability, whereas let's say someone with a very small deletion just to the end is the most mildly affected. Now, there can be exceptions. There are some children that have relatively small deletions that, for reasons we don't understand, still have quite severe intellectual disability. I'll come back to this in a moment, but I will say without exception, for any child who has a deletion from the end that is more than 12 megabases, they are the most severely affected. And that's pretty much what I'm saying on this slide. Again, there's no patient with another way of saying this is nobody that has the higher IQ has a deletion of more than 12 megabases, without exception. And I think these numbers are actually becoming fairly convincing. We're working on, as an aside, we're working on a manuscript now of around 100 patients where we've done these kinds of assessments with the genotyping. And again, anybody who has a terminal deletion, meaning out to the end that's more than 12 megabases, has significant global intellectual disability, and if you just go by full-scale IQ, meaning an IQ of less than 50. This is just another way to kind of show that, so that if you have a relatively small deletion, your full-scale IQ is probably low normal, 75 to 80. If you have a little bit bigger deletion, the full-scale IQ is a little bit lower, maybe mid-60s, and then there's a very profound drop-off once you get past 12 megabases, where that IQ is maybe 40s and sometimes really not able to be accurately measured. Don't worry about the details of this, but basically what this is showing is a detail of the area where that 12 megabase boundary is. And essentially what it means is if you go past 12 megabases, there's a gene that you can see there called BSX. That's what I mentioned before, brain-specific homeobox protein, that we think is the gene that's responsible for the most severe intellectual disability. That's what I have on this slide. And I just want to point out that this is a fantastic example of how collaborations can be so fruitful. I'm obviously not a neurobiologist, but I'm fortunate to be collaborating with the one PhD neuroscientist in the world that happens to be studying this gene. That's Matthias Trier, who is in Berlin. And so he had been studying this, but once we identified this gene, I approached Matthias, and he had never suspected up until that time that this gene causes intellectual disability. So he's been studying this gene in mice, and when he went back and analyzed his mice that are missing specifically this gene, he found that these mice are severely intellectually disabled. And he has done some very, very elegant studies, some of which already have been published, some will be, along with our data, in which he hypothesizes or thinks that this gene encodes a signal that regulates appetite and sleep. He's also shown that this protein is expressed or functions in just a small set of neurons in the brain, including a group of neurons that he thinks is critical for some aspects of cognitive function. And putting this all together, our thinking is that what this gene or protein normally does is to keep this part of the brain that's involved in intellectual function awake. And that if you're missing one copy of this gene, like some of your children are, that part of the brain that's required for high cognitive function basically is asleep, and that's why it's not functioning. And more detail than you need to know, but he has identified what he thinks is a downstream signaling pathway in the brain, in these neurons that BSX regulates, specifically histamine is the chemical or the signal in the brain that he thinks BSX might be regulating. And so when I was interacting with Matthias, I said, this is wonderful, but let's take it one step further. Based on this knowledge, we've got a gene, we think we know at least in part how it's functioning in the brain. Could there be, in your knowledge, any drug that may be already out there that might help to address this problem if you're missing one copy of this gene? And it turns out Matthias was very excited to tell me that yes, not a drug that has to be invented, but one that's already out there that probably not coincidentally is involved in, among other things, regulating histamine. And it's a drug called modafinil that maybe some of you have heard of. And it turns out modafinil is, in the United States, an FDA-approved drug that's used for a few things. One, narcolepsy. So that's probably not coincidental. So people that have this disorder, when you're not jet-lagged, of falling asleep during the middle of the day. It's also used to treat some people with anxiety when they don't respond to some of the other more conventional drugs. And if you do a Google search, you even find some examples of people using modafinil to treat intellectual disability, even though they have no understanding of how or why it might work. So this led to our hypothesis that maybe if we tried treating a child with Jacobson syndrome that's missing a copy of the BSX1 gene, maybe they would improve. So I want to share with you now our first case that is since our last conference 2 years ago about a boy who is 6 years old now, I think, who lives just outside of San Diego, who has an interstitial deletion that's about, I think, 7 or 8 megabases long that includes the BSX1 gene. And Natasha and Sarah have done some very comprehensive cognitive assessments. This is Matthew, good-looking little boy. And so he was, not surprisingly, found to be quite severely impaired intellectually. And so just a few months ago in February, we started him for the first time on modafinil. So this is really our first example of how the clinical assessments has led to the identification of a gene that has now led to a specific drug therapy that we think targets the missing function of this gene. And I want to share with you some of the preliminary results that we have. Now let me tell you this is from his parents. We did a very comprehensive assessment right before starting him on therapy, and we will repeat that assessment 1 year after initiation of therapy. That's how long you need to wait before you can really believe any potential changes. But nonetheless, I want to share with you already what we're learning from his parents, and you can just translate this directly if you'd like. We notice that his behavior is much better. He is able to say more words. Sometimes he has bad days, but not like before. He follows directions and always does what we ask him to. And then this is an even more recent update from April, so he'd only been on drug already for just 2 months. Bear with me, but I'm just going to read this. I will say that the medication, it's working. It is amazing how Matthew has changed from this last month. He is more focused, and he's trying so hard to learn at school. Tantrums have decreased probably by 75%. His speech has improved a lot. He is now able to speak and repeat every word. He is able to answer questions. Cognition has also improved. He retains more information. For example, I left his bike in the back of my car because we went to the park, and I forgot to take it out of my car. 2 weeks later, I was asking my husband about the bike, and Matthew, the boy, told me that it was in my car. I was impressed by how Matthew remembered something from so long ago. His behavior has also improved. He is able to listen and follow direction. So again, that's not scientific. That's from the perspective of the parents, but I think it's very exciting that it seems to indicate that Matthew is having a response. But again, this is July. We're only 5 months into the therapy. I will say that, not surprising, one side effect that Matthew is having is he's lost some weight, but we know that modafinil can cause suppression of appetite, so he gets to eat more. No, not you, Teresa. You can't take modafinil, sorry. Okay, so that's where we are, and I should also say that just in a couple of weeks we're going to start a second patient with a terminal deletion who lives in San Diego, who is also very severely impaired and very anxious. So that's one patient and a second one about to be started. So I showed you this before. This is Robin with her mom, Shirley Olney, who, to my knowledge, was the first, at least that I became aware of, with Jacobson syndrome being diagnosed with autism. And as you heard from the previous talk, that prompted us to do a more systematic prospective assessment of 17 children with Jacobson syndrome, and we found overall about half of them fulfill the diagnostic criteria for autism. And as I'll show you in a moment, it led us to identify at least one gene that we think may be a cause of autism. And this is just a way to show you that if you look at the second one from the bottom, that's a patient who does not have Jacobson syndrome, but does have autism. And it has a very tiny deletion, as you can see there by that tiny little blue area. That happens to be in a region that contains a gene that could be a cause, and that gene is called RICS, which I don't even know what it stands for. This is just another way to show that his deletion is very small, her deletion, excuse me, just involving a few genes, and one in particular, which is also called ARH gap 32. And this turns out to be a very interesting gene that also functions in the brain. And like I told you before, coincidentally, there happens to be one group only that I know of in the world that studies this gene, and they happen to be in Tokyo. And so I reached out to them. And just like I described to you before, I wanted to have them go back and look at their knockout mice for this gene. Question number one, and I showed you this for those that were here at the last meeting. Do these mice have autistic features? They knew that this gene has functions in the brain, but this group studying this gene had never previously suspected that it specifically can cause autism. And again, based on the elegant work that they've been doing to understand what this protein does, could there be a potential drug therapy? All right, so I think I showed you this last time. So these are their knockout mice. So on the left, this is just one of a whole battery of tests that they can do. This is just to show the kind of typical repetitive behaviors that can occur in autism. So on the left is a normal mouse. On the right is a mouse that has just this one gene that we implicated, deleted, or missing. And I think you can appreciate, comparing to the left, that this mouse is engaging in more repetitive digging-like behaviors, reminiscent of what you would see in autism in a human. And they can even quantify this, and sure enough, these mice clearly demonstrate more repetitive behavior. And they did a whole battery of tests to confirm, and I won't go into the details. As shown here, whether you're missing one or actually both copies of the gene in mice, they clearly show other aspects of autism that you can quantify, including social behavior and this kind of thing. And don't worry about this picture, but again, this is just to show you that this group from Tokyo has specifically identified the mechanism by which they think this gene is functioning. And if you look at the left, if you see what it says in that kind of blue elliptical object where it says RICS, so what that protein normally does in the cell of a brain, in the brain, is to stabilize that group of four little vertical kind of balloon-looking things. That's supposed to depict a receptor that's critical for signaling in a pathway called GABA signaling. And it turns out that is one known pathway that's thought to be involved in causing autism if you're missing that pathway, if you have a loss in this balance between stimulating or inhibiting this GABA signaling. And so as I mentioned, I asked them then, with this knowledge, could it be possible, is there a drug that might compensate for the loss of one copy? So in your children that are missing this gene, they only have half as much of that receptor that I'm showing you. So to answer the question, it turns out there is a drug that will directly activate that receptor such that if you only have half the normal amount, then this drug can actually make that half work harder to normalize its function. I hope that makes sense. Slow down? Yeah? Okay. She's with me. Good. And it turns out, similar to what I told you a little while ago, this is a well-known drug that's used to treat anxiety called clonazepam. And so as part of their paper that came out after our initial paper, they gave these mice a single dose of clonazepam, and it seemed to result in a significant improvement in some of those autistic features that I just showed you. In other words, it suggests that it is targeting exactly that receptor that I showed you before, in which there's only half of the normal amount, to boost up its function to compensate for the one missing copy. All right, so mice are obviously not humans, so I want to introduce you to a little boy who is from the Houston area, whose name is Carlos. And Carlos does not have Jacobson syndrome, but he does have, just like analogous to what I showed you before, a very tiny deletion in chromosome 11 that's like what I showed you before, just affecting a few genes, and in particular, the gene that we identified, the ARH-GAP32, or the RIX gene. And Carlos is very severely affected by autism, very severely. So I learned about this family. Actually, they had posted on the Jacobson syndrome Facebook page. And so they were very excited to see if Carlos might respond to treatment with clonazepam. And so we started Carlos on low-dose clonazepam, which I should say it was low dose that my colleagues used on the mice. And again, this is since the last conference here. He was started in February a year and a half ago. And I want to share with you what we've learned in the last year or so. So just before treatment, to describe his problems, he is nonverbal, severely autistic. And I wish I had a picture of this, but one of the things that was the most troubling to this family that I have heard many times about children with Jacobson syndrome is engaging in this self-destructive behavior where they're biting and scratching to the point where they literally have scabs all over their body. He also has anxiety and hyperactivity. So after 2 months of treatment, he was started on a very low dose, and then we raised that dose a little bit, but still keeping it very low because there are clearly side effects. But I want to just describe to you what his parents have conveyed. Carlos has had a significant decrease in his self-injurious behaviors, and his father reports that he appears happier and calmer. His parents are pleased with the benefit from the medication and has not observed any side effects. His teachers have also assessed him, not knowing when or whether he was on drug. His teachers state that he has been making some progress with his communication at school and that his behaviors have improved. Carlos has been noted to have some increased activity where he has been getting into things around home, and sleep is still a problem for Carlos. So that's after 2 months. So let's move out to now about a year since starting therapy. Unfortunately, he began to regress, so we think that he actually has developed some tolerance to this drug, which we know happens with benzodiazepines. So we did increase his dose a little bit, and now he is again showing marked improvement in some, but certainly not all aspects of his problems. So he continues to be much less engaging in these self-injurious behaviors. His irritability and agitation appear to have significantly improved as well. But there are still ongoing concerns. His language really has not improved. He does not gesture to communicate needs. And even if he brings somebody's hand to a specific object, the family ultimately has to guess what Carlos wants, so he's still not communicating. He is still impulsive and hyperactive, often moving around, and still difficult to get him to sit still. So it's exciting, but certainly it's not a total cure in this case. Moving on, a little more information. He engages in repetitive behaviors and interests. He listens to the same parts of songs, stereotype hand movements. He's not interested in playing with toys, but will briefly engage in some games with his sibling. So one of the things that we have not addressed is, like I said, we want to be very careful, and so we've kept him on a pretty low dose. But it's very interesting. The father confided in me that for about a week he was accidentally giving Carlos a higher dose, and his father is absolutely convinced that during that week when he was accidentally given a higher dose, behaviorally he was by far the best he's ever seen. So that's interesting and probably needs to be explored. So we still don't know what the best dose is. Clonazepam, again, can have side effects. Tolerance is certainly an issue. So these are things that we still have to address moving forward, but I think already just with this one patient, there is certainly some cause for optimism that clonazepam may help. And more recently, just in the last few months, we've come across another patient, a little girl from Florida, who has actually just a point mutation, so a mutation just in that gene that causes a loss of function in that one copy of the gene, and we have just started her, who also has severe autism, on clonazepam, so stay tuned. And we're hopeful that we might see some similar response. So I've told you about now 2 patients that really just have basically a mutation in the RIX gene, but what about your children that have Jacobson syndrome that have a deletion that might involve other genes that potentially could also cause autism? And this is just to show you several other genes that may be also contributing to the autistic phenotype in some of your children. So hang on to that thought, and I'm going to come back to that when I talk to you now about some other therapies. So you may remember, for those of you who were here 2 years ago, this little girl who is from the United States. And she was originally diagnosed with autism before she was ever diagnosed with Jacobson syndrome. And for that reason, her parents enrolled her in a prospective study to test whether or not a drug that's used for depression called buspirone could help with her autism. And so don't worry about this very, very busy slide, but this is the paper that they published a few years ago that showed that buspirone low dose may have some benefit for some aspects of autism. But moving back to that little girl, Sophia, she was treated for 6 months with buspirone. Interestingly, she did not seem to have any improvement with her autistic features, but she did have what seemed to be a dramatic improvement in her daily living skills. So over that 6-month period, her daily living skills score improved by about 2 years. And her mother thinks that she's been doing much better with sleep, actually, since being on buspirone. So what do we do with that information? I want to tell you about one more patient of ours, a Jacobson syndrome young lady on the left. That's Kalia. So her family has come to virtually every one of our conferences in San Diego, and over the last several years, her mother knew about our studies with clonazepam and buspirone. I honestly did not know this, but a few years ago, her mother worked with Kalia's psychiatrist to start her, again without my knowing about this, on buspirone and clonazepam. So to tell you a little bit more about Kalia, we had actually done some systematic cognitive testing on her a number of years ago in San Diego, and she's quite significantly impaired. She has an IQ of about 50. And we had not previously assessed her for autism, but she had been diagnosed by her psychiatrist with autism using some of the standard diagnostic criteria. That was many years ago. So again, like I said a few years ago, her psychiatrist started her on clonazepam and buspirone. And I want to share with you, I think I shared some of this with you last time, but then I'll give you a further update. So her psychiatrist believes that she has certainly improved since being started on these drugs, with improved level of functioning since buspirone. She's able to articulate how she feels and process an appropriate reaction, so a more appropriate mood. She stated that she's having less outbursts since starting buspirone. She was hitting herself when angry and seems to have stopped doing that. If she has outbursts, it's more towards others, not her mom. And since starting the clonazepam, this has helped her mood swings a great deal. She seems to be better able to deal with her anxiety. So, that was kind of secondhand information for us. So we brought her back recently since our last conference here. And what we found is a few interesting things. Basically, her IQ did not improve. So we did this whole battery of testing like I showed you before, but coincidentally or not, the one aspect of cognition that she seemed to have some improvement, you see down there in bold, daily life skills. And let me remind you, the little girl that I told you about that was in that trial on buspirone for autism had no improvement in autism, but remarkably had a significant improvement also in her daily living skills. So this is just 2 patients, but it's provocative to me to think that maybe buspirone in ways that we don't understand at the genetic level may help at least with this one aspect of cognition. Again, just to summarize, she did not have any improvement in her full-scale IQ, but did have some improvement in her daily living skills. Maybe some improvement with her autistic features because when we assessed her very recently for autism, she did not fulfill the criteria, even though her previous assessment by her psychiatrist did lead to the diagnosis of autism. But we didn't assess her previously before drugs, so it's a little hard to prove if she really has improved with autism since being started on clonazepam. And this is just to summarize some other potential drugs that people have talked about and shared. We don't really know anything about these drugs, if they really have any specific benefits. But based on what I told you, there may be some argument for, depending upon where your child's deletion is, one or more of these drugs listed here, modafinil and clonazepam based on the genes that we've identified, and potentially buspirone to help with daily living skills. So just to summarize, as you already suspected, I'm sure, we've confirmed that Jacobson syndrome patients have variable degrees of cognitive impairment. We think at least 3 of these genes now contribute to this impairment. Deletion of BSX, presumably in combination with one or more other genes, can cause severe cognitive impairment, really with no exceptions that I'm aware of, at least on our cohort. Even patients with the smallest deletions have at least some mild degree of intellectual disability. We think that the RIX gene is at least one gene that's contributing to autism in Jacobson syndrome. And again, I think we have some very exciting, albeit very early data to suggest that there may be some gene-based therapies available for your children. So we've made good progress. Obviously, there's a lot more to learn. I hope 2 years from now, if we have this conference again, and if I'm fortunate enough to be able to come back, we might have some additional data. Like I said, we're just starting now a second patient with Jacobson syndrome with a terminal deletion on modafinil. I think something that your group might be uniquely poised to do, if I can interest some of the people here today, would be a small prospective study to test your children, perhaps those that are missing the BSX1 gene, to see if they may respond. It's maybe a little bit early, but I think we have some pretty exciting data to suggest that we know it's safe and that there may be a response. In clonazepam, again, we're just starting our second patient. One of the biggest challenges, like I mentioned, is to figure out what the optimal dosing is. I'm a little less excited about proposing a prospective study on that until we have a better feel for what the dosing should be and potential side effects. And last summer at the American conference, some of these families were there and they shared their stories, so feel free to go to the 11Q USA website if you want to hear those stories. I want to thank the team of people both within San Diego and really around the world that have been so helpful to do this work. Obviously, I'm not a psychiatrist, so this is way out of my domain. In addition to Natasha and Sarah, Marty Stein, who is a behavioral pediatrician, has helped us early on, and he's kind of passed that off to one of his colleagues in San Diego, Dr. Yi-Wei Liu, who is our behavioral pediatrician who's overseeing the treatment of these children with both clonazepam or modafinil. And then some of our other basic science people that have really helped us to identify the mechanisms of how these genes work, and most importantly, leading us now to these potentially gene-based therapies. Obviously, the children and families from the United States, and I want to pay particular tribute to all of you, to this group who has made a lot of this work possible as well. And I think I am done. Thank you.